In this first step, we're going to remove the dura from the area overlying the atlanto-occipital joint to expose the dens, which is the tooth-like process of the C2 vertebra, and look at a couple of ligaments that are connected, dens, to the bony structures around the atlanto-occipital joints. First thing to do is to make a sharp cut into the dura in the cervical region. So this is probably at about C3 or 4. Make a sharp incision in that area. Grab the cut edge of the dura with forceps and begin to peel the dura superiorly. Let me grab this one right here. And what you're doing is stripping the dura away from the posterior longitudinal ligament of the vertebral canal, and it gets another name when we get into the region of the odontoid or dens process of C2. This is called the tectorial membrane, and that's right in this region right here. Next thing we're going to do is make an incision into the tentorial membrane and reflect that structure inferiorly to expose these ligaments and the dens. I'm going to try to get started underneath this. Okay, now having removed the tectorial membrane in this region, I should have identified earlier, but for orientation, the vertebral artery on this side, the left side, and here's the vertebral artery on the right side that are coming through the foramen magnum area in order to form the basilar artery. So again, here's the dens in the background, and when we rotate the head from side to side, you can see a little bit of movement there. There's actually a tough ligament that goes across from side to side, crossing the dens or the odontoid process, and it actually extends superiorly and inferiorly a short distance. This is the cruciate ligament. Okay? We're going to be cutting the region above the dens, which is very obvious when you rotate and or palpate. And we're going to cut two relatively small but yet thick, dense ligaments that are wing-like, that extend upward and laterally, right in this area, from the dens to the occipital bone. So one on the left side, and there's one over here on the right side. So we're going to quickly cut those. Across the middle here would be the superior branch or component to the cruciate ligament, and then an alar ligament I just cut through on the right side, and another one on the left side. And you can push aggressively through these thick, taut ligaments till you feel bony tissue on the other side. Okay? What we're going to do now is to separate the head from the remainder of the cervical vertebral column. And to get started on that, we need to turn the cadaver over and begin to do some blunt dissecting in the retropharyngeal space. Now that we've repositioned the cadaver in a supine position, what you need to do is to identify the carotid sheath which will underlie the sternocleidomastoid muscles. And here on the left side, we didn't do as complete a dissection as we did on the right side. But for orientation, here's the internal jugular vein, the omohyoid, and some of the fat that overlies the posterior triangle of the neck region. And what you need to do is to blunt dissect behind the carotid sheath and its contents. And how you know you got the right things: look for the internal jugular vein, the common carotid artery, and the large vagus nerve. And blunt dissect across the midline in the retropharyngeal space. And continue that blunt dissection as far superiorly as your fingers can access to the base of the skull, and work a little bit inferiorly as well. Usually there's a couple of problems with the sternocleidomastoid muscle that you have to maybe make a few cuts of some of the nerves that are going, in this case, from sternocleidomastoid to the trapezius. Here's a external jugular vein. We can work around those, but if they're in your way on one side, in order to free this up as far as possible, you may have to do a little sharp dissection on that side. But I'm going to reposition the cadaver over on the right side to finish the dissection and more clearly show the structures that you need to preserve that will stay anterior with the pharynx, larynx, strap muscles, and all the tissue you see in the anterior neck region. Okay, on the right side, here's the sternocleidomastoid muscle. We're going to reflect that, which you've already done. You might know, depends upon what you found in your own dissections, branches of the cervical plexus, cutaneous nerves. Here's one that's running towards the earlobe and just at the base of the ear or a little anterior to it, the great auricular nerve. Turn this back, the sternocleidomastoid, as far as you have reflected it, and relocate and identify, for example, here is the ansa cervicalis. So this is a good time to review a couple of things just to make sure you have them and can save them. That's the point of this. Here's the right common carotid artery. We've already reflected the internal jugular vein. Directly posterior to the carotid and still within the carotid sheath is the vagus nerve that you see right here. And then posterior to that is the cervical sympathetic trunk. And it's a structure that lies closest to and right against the deep neck muscles. And if you look superiorly along the sympathetic trunk, usually you can identify the large gray swelling of the superior cervical sympathetic ganglion. Okay? The point is we want you to protect and save the sympathetic trunk so that it comes anteriorly with the structures that you're separating from the vertebral column. The cervical plexus over here will have to be branches cut down deep that are going to the cervical nerves so that we save, these are the connecting branches between adjacent cervical nerves. The brachial plexus is right in this area, so that we can have these structures come superiorly with the contents of the neck region. Okay? So the point, just to demonstrate the kinds of things to try to save, and then again, you should be now able to dissect freely across from right to left the entire retropharyngeal space, and again, push superiorly till you feel the base of the skull, and just with your fingers break down the soft tissue fascia, which is fairly delicate here, to blunt dissect all the way. Then the last step for removing the actual head from the vertebral column will be to quickly reposition the cadaver in the prone position and make some scalpel cuts down to the atlanto-occipital joint. But it helps to have isolated all of these things first so that when you start making some scalpel cuts, you're cutting the right things and have already preserved the things that you want to study a little later. Okay, here we are, the cadaver back in the prone position, and I'm first going to be doing some sharp dissection here along the sternocleidomastoid muscle, its posterior border, and cutting right to, with the scalpel, right to the base of the skull and the occipital bone, and that will help expose the atlanto-occipital joint. But just to reconfirm and get oriented to the retropharyngeal space, place your hand across the midline from right to left, and that should be easy to do if you did the preceding procedure properly. And so we're going to be cutting, beginning where you see my fingertips, but not the fingertips, and beginning to cut right up there to the base of the skull. So let me see if we can do that. I'll pull this taut, coming in this direction. Widening that gap here and getting right down. All of the muscle tissue that we might be cutting through here would be upper portions of levator scapulae and the deep neck muscles that we don't study. You will probably run into the vertebral artery again as you get into this region. You stay superior to that. And use a little blunt dissection of provolone. You can easily feel that transverse process that's very prominent of C1, and you can feel the base of the skull, and you know you're in the right interval right there. So I'm right down now on the atlanto-occipital joint. So now we'll take a chisel, and sometimes either it'll wedge free, depending upon how the dissection goes, or use a hammer to open up that joint. And it's really important to try to get between C1 and the base of the skull. in order to really not include this first cervical vertebra in your dissection procedure. That will just make it more difficult when you are trying to identify structures in the next dissection. So I'm just breaking through the osteology and the ligamentous structures associated with the atlanto-occipital joint. If I drive a wedge in there now and try to pry that open so you can see it on the camera, I don't know if that'll work, but we'll give it a try. Vertebral artery is in the way a minute. And there's the atlanto-occipital joint. Actually, I'm not sure that you can see and appreciate that real clearly from the angle. Let me see if I can spread that open a bit. There we are. So here's the plane that you want to be for finishing this dissection. Right there between the occipital condyles, C1, and the base of the skull. And so I'm going to do that on the other side, and then everything should be free to just fold the head anteriorly away from the vertebral column and save all of the structures that you've so carefully dissected up till this point. Now on both left and right sides we've opened up the atlanto-occipital joints with the chisel, and what that allows you to do is to flex the head relative to the vertebral column, and sometimes or usually you have to, here's the dens right here, and we've already cut the cruciate ligament, but you have to reach in and cut across the midline because there'll be some ligaments or tendinous structures of the deep neck muscles that have to be completely severed in this area. And since you've already done a nice job to protect the structures of the carotid triangle, etc., there's no danger of going too deep there. So you can see now this is really loose and coming off, and blunt dissection. I'll try to finish this off and show you kind of what the goal is and what you gain by doing it this way. I can feel a... Now what happens in the finished product, and this will be a little easier if we were to turn the cadaver over, but I just want to, if you're in the right plane, you will be having exposed the anterior visceral compartment of the neck, and the fascia that we're looking at here is the buccopharyngeal fascia that surrounded the visceral compartment. All of the structures of the carotid sheath have been protected and saved, and we're literally looking at the back of the pharynx in this area. Here's the base of the skull. And the head can then be completely folded down. You'll turn the cadaver over, and this will be a little bit more obvious and easier position. But when you do the dissection back here, you now have gained the access to do that, but you've not had to transect any of the great vessels and nerves that you dissected in the carotid sheath, so they're all preserved for your review. Okay, having separated the head and the anterior neck compartment from the vertebral column back here, this is you'll be able to fold the head and neck compartment back and forth to easily review, and yet still retain some continuity with the aortic arch and other structures of the superior mediastinum or thorax. And again, here would be the retropharyngeal space, and this communicates down inferiorly into the posterior mediastinum through this hole you see here. So what you're going to do when you first expose this is see a fair amount of fascia that's lying on the pharynx. This is the pharynx right here. But we've already removed most of the fascial pieces that overlie this area, the buccopharyngeal fascia, and this would be one of the boundaries of the retropharyngeal space. So for orientation, then we can see on both sides the sympathetic trunks, the cervical sympathetic trunks, which have the distinctive grayish dark large ganglion. Here it is on the other side, the cervical sympathetic trunk. You can see the carotid artery on both the right and left side. On the right side, the internal jugular vein has been removed. On the left side, it's right here. So the carotid sheath contents are exposed right here. A midline structure down the posterior side of the carotid sheath, of course, is the vagus nerve. One helpful tip for differentiating sympathetic trunk from vagus nerve once you've dissected, because they're both not in the carotid sheath, just the vagus nerve is, but once you've dissected all the fascia, then they'll lie as parallel elongated nerves The sympathetic trunk will always be medial to the vagus, and it will have the characteristic superior cervical ganglion. And what we need you to do is begin to peel away, pick away the buccopharyngeal fascia, and what you'll start to identify will be some nerve fibers that are fairly delicate on both sides here that come in at an angle, descending inferiorly and medially over the muscles that comprise the constrictor muscles of the pharynx. And we'll identify those in a minute. But just to give you some examples of these stringy nerves that are comprising the pharyngeal plexus. And these nerves are derived from three sources: the vagus, the sympathetic trunk, and the ninth or glossopharyngeal nerve. Once you find some branches, simply trace them back to their origin to see whether they're coming from the sympathetic trunk or from the vagus or from the ninth cranial nerve. The innervation or destination of those nerve components is something you need to also learn. Primarily, we want you to focus on the vagus and the glossopharyngeal. The sympathetics are just doing some vasoregulation of blood flow through the pharynx. Okay, if you also when you finish that and expose more of the pharyngeal constrictor muscles, on both sides you should be able to identify the stylopharyngeus muscle. The middle constrictor is just inferior to where the stylopharyngeus muscle sort of disappears, and the superior constrictor will be above that point of insinuation. And this particular specimen, the superior pharyngeal constrictor, seems very degenerated, very thin, and maybe had a denervation problem. We're not sure. But use that landmark of stylopharyngeus to identify those two muscles. Then wrapping around the stylopharyngeus muscle will be the ninth cranial nerve, the glossopharyngeal nerve. And they're delicate branches that come off the glossopharyngeal to contribute to the pharyngeal plexus. The inferior constrictor muscle, we freed up its inferior border such that I'm now insinuating the probe or forceps here on this side to identify the inferior constrictor. Those are the three constrictor muscles and some of the nerves associated with the pharyngeal plexus. There are two other cranial nerves that would be worth re-identifying here at this point. We did the sympathetic trunk on both sides, we did the vagus nerve, but you can also identify the 12th cranial nerve and the 11th cranial nerve in this dissection. It's kind of a good way to review both of those nerves and further trace the course of those nerves as they exit the base of the skull. So what I'm doing over here is identifying the internal jugular vein, and I'm holding the sternocleidomastoid muscle, and look for the spinal accessory nerve, cranial nerve number 11, that descends obliquely, pierces the muscle, and then is obviously going to continue beyond to the trapezius. Also, you can identify, if you go between the carotid artery and its bifurcation and the internal jugular vein, you can identify the 12th cranial nerve. So this is a nerve that descends from the base of the skull very close to the vagus, but it will have a much shorter course as it turns laterally and then anteriorly around the external carotid artery. And you recall, although we're not showing it here, that it travels in that direction towards the tongue by wrapping around the origin of the occipital artery. The next step will be to incise the midline raphe of the pharynx to expose the inside of the pharynx. To examine the internal anatomy of the pharynx, we will need to make a scalpel incision down the midline of the back of the pharynx. There's actually a line of insertion of the right and left pairs of constrictor muscles called the pharyngeal raphe. You probably won't see that very clearly, but that's basically the target for where this incision will be. Let me do it right down the midline here. And then fold back, you completed your incision, fold back the layers of the pharyngeal wall, or the constrictor muscles. And depending upon the cause of death or timing of death, you may see some debris, as in this specimen, within the pharynx and openings communicating anteriorly. I'm going to clean that up for a second and then come back and go through identifying the anatomy of this region. Okay. Now we have the pharynx open posteriorly and have cleaned this out. All of this area right in here where I'm laying the probe is portions of the pharynx. And the openings of the pharynx are anteriorly. One opening anteriorly is up towards the base of the skull, so I'm putting the forceps into the opening into the nasal cavity. If you look into the nasal cavity, you can actually see the nasal septum way back in there. Just the floor of the nasal cavity and the roof of the oral cavity would be comprised of what we see here is the soft palate, which I'm moving back and forth. And of course, going in this direction is going into the oral cavity. And this is literally the dorsum of the tongue that we see in this vicinity right here. You can make out the circumvallate papillae when you do this, sort of a V-shaped or chevron-shaped series of taste buds that will help you differentiate anterior 2/3 of the tongue from the posterior 1/3 of the tongue. Okay? So this is all oropharynx, part of the pharynx that communicates with the oral cavity. This region is all nasopharynx that communicates with the nasal cavity. Inferior most component of the pharynx is down here I'm tracing as the laryngopharynx, and it communicates inferiorly into the esophagus. The opening in the laryngopharynx that also communicates in an anterior direction is right here where the forceps are, and this is the inlet to the larynx. So this structure right here, which is movable, is the epiglottis. Descending down into this opening is going into the airway system, the trachea, and the lungs. So laryngopharynx, oropharynx, nasopharynx. I mentioned the soft palate up here with the as a border between the nasopharynx and the oropharynx. I didn't mention the uvula, which is the little pointed piece of the soft palate. Within the oropharynx, and if we bend down the epiglottis, and I hold the head up maybe a little bit better, you can see into some depressions that are pockets off the midline. And in the midline is a fairly prominent ridge. This ridge of tissue and mucous membrane goes from the epiglottis to the tongue. So it's in the midline called the median glossoepiglottic fold. And to the right and left side are some deep pockets on either side of that fold called the vallecula epiglottica. This is another area where foreign objects that are, or sharp objects that are swallowed can get caught down into these pockets. Another fold that borders the vallecula epiglottica is a fold that goes laterally from the epiglottis to the tongue, and that's I'm tracing right here. This is the lateral glossoepiglottic fold, and in the midline is the median. Now, on the posterior 1/3 of the tongue, when you identify that with the circumvallate papillae, you're basically looking at the location of the lingual tonsils in this region. We turn down into the area of the laryngopharynx, and in addition to making sure you're clear about the inlet or additus to the larynx, there are some subdivisions or recesses, pockets along the margins of the laryngopharynx. These are like troughs or gutters, and these are the pathways that food and liquids take when we swallow. The epiglottis can move a little bit, but it primarily functions as a shield so that a bolus of food or liquid that comes through the oral cavity hits this structure and is deviated to the right and left sides into these recesses. These recesses are quite deep in some areas, and these are called the piriform recesses, a common place for fish bones and other sharp structures to be trapped. Then they become very shallow as we descend into the esophagus. The only other thing I think is worth mentioning here is all of this is lined by mucous membrane, and from the pharyngeal plexus that we just talked about on the external surface of the pharynx, keep in mind that the mucous membrane lining the pharynx is sensory, and the nerves that contribute to the sensory innervation of the entire pharynx are the pharyngeal nerve for the nasopharynx and the oropharynx, and branches of the recurrent laryngeal nerve or vagus nerve for the laryngopharynx. So right about at the border of the epiglottis is the dividing line between pharyngeal sensory innervation above and vagal. The next step in this dissection is to dissect the submandibular triangle, and this will immediately precede the final step in this dissection, which is bisecting the skull. The submandibular triangle, for a little orientation, here is the hyoid bone lying right here in this position, mandible here, anterior belly of the digastric, which you previously dissected, so I'm going to fold that down. And it contains one of its more important contents is the submandibular salivary gland that you see right here. This has a superficial and a deep portion. You'll probably be able to move the superficial portion fairly easily out of your way. The deep portion will sneak underneath the mylohyoid muscle that's shown right here. Another landmark here is branches of the facial artery as it courses over the mandible. So one of the things you want to do, and on the other side here is the anterior belly of the digastric on the other side. I'm going to peel that back. That was done previously. One of the things you want to do early on in this dissection is to take a saw and cut through the midline of the mandible, and just enough so that you get through the bone and not any of the soft tissue. And this will allow you to pry and move the mandible in positions that will facilitate your dissection. Having done that, then when you need to make a sharp midline incision through the right and left attachments of the mylohyoid muscles. This is another one of those seams or raphes, and it's already been done here, but you can see then that you can reflect this muscle as a thin sheet-like muscle, leaving it attached to the mandible, and just lay it up and fold it back over the edge lower border of the mandible. That will expose a midline muscle or pair of muscles that go from the hyoid bone to the mandible. This is the geniohyoid muscle that we studied a little earlier. And I put the probe underneath that muscle so you can maybe perhaps better see its borders. I didn't mention, but let me just quickly go back and do that the innervation to the mylohyoid muscle is something we studied earlier, and you'll probably encounter it as a nerve that's a thread-like nerve sitting on the surface of the mylohyoid. And this is, of course, the nerve to mylohyoid that also gets the anterior belly of the digastric. So reflect the mylohyoid, identify the geniohyoid, and then now with the mandible fractured or cut there in the midline, you can pry that back a little bit to see some of the deeper structures in the submandibular triangle. This is the submandibular gland superficial portion. Its deep portion is largely, in this case, a hollow duct, the submandibular duct, that runs from the gland towards the floor of the mouth. So it's coursing in this direction right here. In the background is yet another muscle that we have not studied, and this muscle is the hyoglossus muscle. So let me move the salivary gland and its duct out of the way so you can better see this underlying muscle going from hyoid bone up into the tongue. Its fibers slant slightly laterally as they ascend, whereas the geniohyoid muscle is vertically positioned. So the fibers off here to the side that are angled a little bit are fibers of the hyoglossus muscle. Remember, muscles that have the word glossus in their name, with one exception, are innervated by the 12th cranial nerve, the hypoglossal nerve. And the 12th cranial nerve is shown right here. And this nerve lies on the hyoglossus muscle. The hyoglossus muscle is actually a good landmark for a number of structures in this area. Those that sit superficial to it, and one structure that lies deep to the muscle. So the structures that are superficial to the muscle are the 12th cranial nerve that we're looking at right here, the duct of the submandibular gland, which I'm tracing here, and then kind of wrapping around a couple of times the duct is the more anterior portion of the lingual nerve. So now I'm tracing the lingual nerve. Remember, this is a branch of V3. You saw its origin in the infratemporal fossa. Now you get to see its termination. When you look at the lingual nerve, you will see that it has a very distinct arch or curve to it in the submandibular triangle. And that arch is a good landmark for you to notice a connection or a wad of tissue that goes from the lingual nerve, right in here, run from the curve of the lingual nerve down towards the salivary gland. This is the location of the submandibular ganglion. So lingual nerve, submandibular duct, hypoglossal nerve, superficial to the hyoglossus muscle. The one structure that is deep to the hyoglossus that we want you to identify is the lingual artery. This artery starts over here off the external carotid. As you trace it medially, you'll be able to pick up this artery as it dives deep to the lateral border of the hyoglossus muscle. Right here's the lingual artery. And then finally another muscle, just to see its terminal part, we saw a part of this muscle before. It's a muscle that comes from the styloid process and blends in with the hyoglossus. So there's an interdigitation of fibers right here. This is the styloglossus muscle. Styloglossus, hyoglossus, geniohyoid. Okay, at this point we're going to bisect the head almost mid-sagittally. We'll go off the midline just a little bit, but for orientation here you want to flip the head of the cadaver in this position. And sort of as a target here to start, we're going to be cutting through from a superior inferiorly through the skull, the base of the skull, crista galli, and the pituitary stalk, and the internal carotid arteries and optic nerves are here. So we're going to direct a saw cut that is real close to the midline, but just slightly to the side of the crista galli. You probably need a couple of pair of hands to stabilize the bone or the head while you cut through the bone. Take a saw and begin to score through until you get a score line going, and then keep working inferiorly. You want to keep sawing inferiorly until you feel the cutting edge of the saw just break through the hard palate and the bone, and you'll feel that all of a sudden you're past bone into soft tissue, and stop immediately. Usually at that point you can spread the cut halves of the head apart and take a scalpel to something sharp to cut through any remaining soft tissue that you see. So you end up with an exposed mid-sagittal view of the head. And I want to take a scalpel and cut through the soft palate here so we get a nice clean cut there to complete this. Here we've completed the saw cut part of the splitting of the head or bisecting of the head, and I've cut through the soft palate with a scalpel here and on the other side, with a little more uvula showing on the other side. But for orientation, this is the nasal cavity. Here's the nares. This is the hard palate coming back to the soft palate. And this would be the opening between the nasal cavity anteriorly and the nasopharynx posteriorly. The sphenoid sinus is another good bony landmark just superior to this region. So within the nasopharynx, you will want to identify an opening for the auditory tube or the eustachian tube. This is bounded by a very large prominent ridge of both cartilage and mucous membrane. This bulge right in here is called the torus tubarius, and it extends down into the pharynx as a elongated fold. The dissection continues with exposing two muscles, skeletal muscles, that are attached to the area of the cartilage and the opening of the eustachian tube. Levator veli palatini and tensor veli palatini. To identify those, on one side at least, I suggest that you make a sharp scalpel incision in just through the mucous membrane. I've done that over here on this side, and in another position along here, and then go back and remove that mucous membrane to expose this small skeletal muscle. Okay, once you remove the mucous membrane in this region just below the torus tubarius, you will see a columnar skeletal muscle called the levator veli palatini. It runs somewhat obliquely, but more or less straight in a vertical position to insert into the soft palate. Just anterior to that and more lateral or in a deeper plane from this, you'll dig around in here, you'll see the mostly whitish tendon but some skeletal muscle fibers forming the tensor veli palatini, and that is hooking around the hamulus down deep in here of a little bit of bone you see here, the pterygoid plate.